لا يا باشا، سعادة الباشا. والله يا باشا صدق.
بسم الله الرحمن الرحيم. Now we came to the session of the interventional radiology or interventional imaging, and I have the honor to الحقيقة ان انا اشارك استاذي العزيز استاذ دكتور محمد طعيمة الجلسة واخويا العزيز استاذ دكتور اسامة زين. And good morning everyone. And I have an honor to present the first speaker of the first presentation, which is titled Burning the Capsule, How I Dealt with Peripherally Located HSSC by Professor Dr. Hisham Saeed from Bani Suef University. تفضل.
Good morning, everybody. I'm Dr. Hisham Saeed, Chairman of Radiology in Bani Suef University, and I would like to express my feeling of being honored for being here with my radiology colleagues in the Egyptian Society meeting for nuclear medicine and radiology. And today I'm going to present my experience with peripherally located hepatocellular carcinomas. According to the European Society for Study of the Liver, in an article published in Journal of Hepatology in 2018, peripherally located hepatocellular carcinoma has been a debate for two main reasons. One of them is technical, because the subcapsular location is a risk factor and may be not very effective. And the other thing is the risk of complication, which they are liable for hemorrhage or for bleeding or rupture, tumor rupture, and so on. Other locations may have their own implications, like those lesions located very high in the dome of the liver, which are hidden by the pleura, or sometimes those lesions lying low down near the porta hepatis, which lie very close to the vessel and make them liable to the heat sink effect. As you can see here, the lesion lying close to the big vessel, the flowing blood in the vessel acts like a radiator or a coolant. It takes out the heat and washes it out, so you end up with a small rim of active tumor tissue very close to the vessel, which is not ablated. Other locations in the liver have their own specific criteria. For example, lesions located at the undersurface of the left lobe are very close to the bowel and pancreas and stomach. Lesions on the right side on the undersurface of the liver are close to the gallbladder. And some authors have said that the peritoneal covering of the liver acts like an insulator. So it likes a protective effect of the heat of the radiofrequency. So this protection is absent when we are dealing with the gallbladder on the right lobe. In addition, exophytic lesions or pedunculated lesions have their own implications, should have their own calculations. And other peripheral lesions, each lesion will have to deal with according to its main location. We are going to have a look on some cases from my practical experience. This lesion lying on the anterior surface of the left lobe. The typical approach, I would go from obliquely like that at the demonstration shows, and go taking a rim of liver tissue around before entering the lesion. However, this location was difficult because we have a lot of costal cartilage which are tough to pierce, and the ribs are crowded, so I had to go from an opposite or direct perpendicular approach like this, piercing the tumor directly. And I have to keep the tip of the hot needle, the hot tip of the needle totally inside the liver to avoid cooking the muscles outside. And after 1 month follow-up, I can see here that I had complete ablation of the lesion and the patient had no complications. Other lesion located on the posterior surface of the liver, I had to go through a long distance to reach the lesion, but I have to keep a small distance between the tip of the needle and the diaphragmatic surface to avoid burning the diaphragm. And this was about like 0.5 centimeter distance, and we ended up with complete ablation here, so satisfactory, and again the patient was happy with the results, no complications. This lesion lies a bit higher, and these lesions may be difficult to see. So sometimes when dealing with a lucky patient who is able to have a good breath, long prolonged inspiration, and through subcostal approach you can see the lesion in this case and put the needle inside and again get a satisfactory results. Another lesion lying in the left lobe on the undersurface close to the ligamentum teres, and again this was not a big deal, but typically I would go in oblique manner like that, but I wanted to avoid burning a long surface of the liver to minimize the effect on the bowel and the pancreas. So again I preferred to go directly like that, and we ended up with fairly good ablation, and this is the follow-up after 1 month. And after 3 months, you can see also the lesion has shrunken, and you can see here scar inside the lesion, the burned area. On the right side, the gallbladder may be considered as a trap, so we have to keep a bit longer distance between the tip of the needle and the gallbladder because there is no peritoneal coverage. I was a bit cautious. I keep a distance like 1 centimeter away from the gallbladder, and again I could get a good result and complete ablation of the lesion, and the capsule here is involved also, but the patient has no problem with gallbladder. Lesions at the porta hepatis may suffer being very close to the portal vein or the IVC, and you can see here these lesions like at the bifurcation of the main portal vein into right and left branches. These lesions I deal with just trying to inject some pure alcohol to achieve ablation of the rim of tissue close to the vein. I put a spinal needle close to this area and inject few cc's of alcohol, and then do the RF, and finally the results was very satisfactory in this case. I have to confess that this may not be successful in every case. Sometimes because controlling the alcohol injection is not totally controlled. So sometimes you don't get the effect that you need, but it works in many cases. So we can see here this one of the cases, successful cases. You can see to complete ablation very close to the right portal vein. And if you look here, there is another lesion in the segment 2 of the left lobe, and this also is ablated, satisfactory, and this is the follow-up. This is another lesion, not strictly subcapsular, but it was a big lesion like 4 centimeter or more. I have to use a bigger needle, the cluster needle with a cool tip, and the ablated area was big enough to reach the capsule and possibly the gallbladder. This patient suffered significant pain, I remember, because the ablated area was a bit bigger and very close to the intercostal nerves here, but after 1 month and 3 months, he came for follow-up. He had complete ablation, and again, he was satisfactory with the results, although he got a prolonged pain for some time, but the end results was very satisfactory to the patient. This is an example of TACE-aided lesions. When the original lesion is ill-defined and you can see with ultrasound, we refer the patient for TACE. Sometime after TACE, the lesion takes the lipidol and becomes easily visible by CT, so we can go under CT guidance and do the ablation. Actually, I don't have the pre-intervention images, but and at least we can see here that there no activity on the rim of the lesion. We had a complete ablation in this case. This is an exophytic lesion located at segment 6. This patient had particularly had a broad base, which made me considering to go through this base and go slightly inside the lesion. I was afraid that it may rupture or may undergo bleeding or so on. So I kept a relatively longer distance between the inner surface of the lesion and the needle, like 1.5 centimeter, and did the ablation. And I was quite happy with the end results. We had complete ablation of the lesion, and follow-up after 1 and 3 months showed no recurrence. So again, okay. This is the last case, a lesion lying up under the diaphragm. Actually, there are two small needles, two small lesions very close to each other, which warranted to put two needles, one in transverse direction and one in the perpendicular direction. Under full inspiration, the patient was very cooperative, and he was lucky, and then we have a good ablation also. So to come to a conclusion, capsular and subcapsular and exophytic location per se should not preclude radiofrequency, and morphology of the lesion may have an effect on this. So we have to consider every case, case-by-case basis. You have to plan for every case, and keep in mind that alcohol injection may have a role and give an adjuvant therapy as a given option to the patient in juxtavascular lesions. Thank you very much.